a little bit more of a focus on pelvic floor or internal. Dr. Elias last week talked about, and the week before talked about pelvic floor issues particularly. So she's going to focus more on that. And I'm also going to incorporate more of the halachic Yoetzet halacha component, like a little bit of a different focus, like a little bit less on global functioning and also a little more interface on particular cases where in my practice as Yoetzet Halacha, I found that it's been really, really helpful to partner with a PT. Okay, so with that, I think that we will begin. Dr. Moses, you want to maybe for a second explain what it means to be what exactly it means, your background, and what it means to be the specialist that you are.
Yeah, so thanks for having me, you all. I'm really excited. I've had a couple of conversations with Atara already, and they've been so insightful. So I'm really excited to be here with you. I am a physical therapist. I graduated a few years ago, and I got my specialization in orthopedic manual therapy through the Orphansby Institute. And then I got my pelvic training through Herman Wallace Pelvic Rehabilitation Institute. So basically, I specialize in the pelvic floor and its function and just how it affects women, men, and children in their daily lives. So I'm in Memphis, and I co-own Mojo Pelvic Health, which is a pelvic health business where we are in multiple locations around the area. We're in doctor's offices and in Sandara Wellness Center and Mid-South Orthopedic Rehab. I think everyone's here is in Memphis. Is that right?
No, not everybody actually, but most everybody.
Okay, well, we're around Memphis, but we are branching out into other states in the Mid-South. So, but yeah, I'm excited.
Okay, thank you so much. So I think that Dr. Moses said that it's good to take a second sometimes to do a little bit of a self-survey before we begin our conversations. I'm going to take a minute and let you scan these questions. We'll just have literally like a minute of quiet while you get to just read these as a way of framing the conversation and prepping some of the ideas that we're going to be talking about tonight. Again, like, just a little as you scan, I'm going to just distract you for a second. We touched on Dr. Elias, who I think is also on this call, which is so amazing to see. Thank you, Dr. Elias. We talked about a lot of these issues before, but more of a global sense. Dr. Elias talked about the pelvic floor as, we remember, the Pringles can, which I think is an amazing image, and I've actually talked about it probably with 10 people since I learned about it, because I think it's such a good, my daughter, I talked about it with two of my daughters. We just moved recently and we were lifting things, and I was like, think of a Pringles can, like strength, like think of the bottom, the top. It was, breathing out fully. My daughter had a corona test and it was very stressful to her. So I talked about breathing and I had her imagine the Pringles can. So we're going to be zeroing in now, like doing we did a little more of a general, the first two sessions was more of a general overlook. And now we're zooming in on issues of the pelvic floor. And in order to frame the conversation, and like the way that Dr. Moses said, is that sometimes people say like, oh no, really, I'm fine. I'm really fine. I had my kids 20 years ago or 10 years ago. I haven't had kids. Or I really bounce back quickly, quote unquote, bounce back. Dr. Elias talked about that phrase, bounce back, which is crazy. We're not basketballs. But like sometimes we might not realize that there are things that are related. So I'm going to stop talking and we'll read this now for a minute and then the next one for a minute, and just to frame for yourself where your relationship with your pelvic floor might be headed. So the format that we're going to be using is for the next like 45 minutes, we're going to be looking at 4 different areas, like 4 different questions that might be relevant, and talk about some areas where we might have some questions that I've gotten questions as a practice of Yoetzet Halacha, somebody who's been working with women who are getting married, who are married at various stages of lives, and issues that I've seen come up that, or my fellow, sometimes it's fellow Yoetzot that have these particular questions, but things that come up in conversation with Yoetzot Halacha, and issues of Tara Mishpacha, issues of marriage, intimacy, and interfaces where I'll get a question that sometimes one of the really big benefits of asking a question of Yoetzet Halacha is that I'll get a question, somebody will ask something purely as a Jewish law question, but as part of the conversation, I'll say, you know what, it sounds like there's something else that's going on. And I'm not a medical professional, and I'm not a PT, and I'm not a therapist, a psychologist, a GYN. I'm none of those things. However, I am somebody who sometimes can see some symptoms that I don't know where they're coming from, but one of the places that they're coming from might be something that could use an assessment from a professional who does deal with these issues. So so the conversation now will be 4 different arenas that a Yoetzet Halacha might some questions that she might get that really could indicate that a referral to somebody like Dr. Moses or Dr. Elias is required or is helpful. And I'd like to really, really stress we're not diagnosing anything here. Everything that I'm saying is not from the perspective of diagnosing. It's not from the perspective of saying that there is an issue, God forbid, or that treatment is needed, but it's a red flag. It's something that might be worth checking out, and going for a proper assessment, because proper assessment and more information can help us change things. Something else that Dr. Elias and Dr. Moses have each said on more than one occasion is that pain and dysfunction is not something that you have to deal with. People often will say, oh, when you have a baby, blah, blah, blah. Oh, when you're a woman, blah, blah, blah. Oh, as you get older, blah, blah, blah. But it's not necessarily true. Really, the message that I've gotten from them time and time again is that there are things that we could do. There are things that you could do. There are things that we can do to make a difference. And not everything can be solved, but most everything can be. If it can't be solved, it can be mitigated. You can get things better, and it's worth it trying. It's really worth it trying, instead of saying, oh, I'm going to have to deal with this and it's very painful or uncomfortable or whatever. Okay, so the first question we're going to discuss is going to be when I and other people teach somebody who's anticipating getting married. Okay, so somebody who's getting married, and we have the question that we have, like one of the questions that I always ask, one of the very, very first questions in my first or second session that I have of Kala classes, classes with somebody who's going to be married, and is learning about Hilchot Nida, I will say, have you ever tried to use a tampon? And the reason that I ask that question is that part of marriage, both in terms of halacha and in terms of intimacy, involves things going into the vagina that have normally not, might not have gone before, both in terms of doing a bedika, in terms of doing the internal examination to make sure that somebody's period or menstrual or uterine bleeding has in fact stopped, and during penetrative intercourse also, it's going to be important to realize to make sure that a woman is going to be able to consummate her marriage as she wants, and that there's not going to be some issues. And sometimes somebody will say to me, oh, I've tried to put a tampon in before and it hasn't worked. Or if a woman starts practicing bedikot, she'll say, I just can't get it in. It really hurts. And there's many, many different reasons why a woman might not be able to do an internal examination with a bedika cloth, or might not be able to get a tampon. There are many, many, many reasons. It's extremely important to realize that it could be structural physically, it could be emotional, it could be that she's having, anxiety with all sorts of things, because if you haven't really noticed, that being engaged can be a very anxious time. She could be anxiety about intercourse. It could be that she has a difficult relationship to halacha, and that's giving her anxiety. It could be that there's previous trauma. It could be that even physiological, Dr. Moses will talk about in a little bit, that it could be that there's some structural issues in the way that her body is set up. It could be that there's a tremendous amount of nerve density. Sometimes people have up to 100. I heard from a gynecologist who specializes in this, that she once had a case of a woman who had many times, like 30, 40 times more nerve endings in the vaginal area than she was really supposed to, which meant that she was having a lot of triggering pain. The lesson is that if somebody comes to me and says, I've never put a tampon in because it hurts too much, or I'm having a lot of trouble with a badika, then it's really important for us to address this, because the flip side of that is that if when a woman that I work with gets married, so we know that when a woman has intercourse for the first time, then she becomes tme'ah. Generally, like if anybody has questions about that, we can talk about that some other time. But generally, a woman becomes tme'ah when she has intercourse. And then there's halacha, like everything else who discusses Jewish law, has what to say about everything. So of course, there's also a definition of what is the definition of intercourse? How far does it mean that a woman actually has had intercourse for the first time? And sometimes I always tell women that I work with, that I teach with, I always say, like, if she has not had sexual intercourse before, then sometimes she might not be sure what exactly happened. And I always tell women that I work with, my phone is going to be on. You could call me and 24 hours a day if you're having problems, anxiety. And if I have a conversation with a woman, like sometimes it just, it might take 1 or 2 times, a day or two, or even a week or two. But if it takes longer than that, then the couple is really having problems, then that is going to be a time that I'm going to say, well, after whatever limited amount of time that might be trying, and she calls me a few times and says, I don't know what to do, this is not working, I'm having a lot of pain. When I hear that phrase, I'm having a lot of pain, or it won't go in, then I say, okay, this is we don't want to cause further anxiety, we don't want to make the problem worse, and we want to see what's going on. And God forbid, a woman should never do something that really is painful to her. Like, people will say, oh, it hurts for the first time. That doesn't mean that's not to the extent of dysfunction and tremendous pain. And if a woman is saying it just hurts too much, I can't do it, then we would never, God forbid, say, no, try harder. We would say, let's get you help sooner rather than later, meaning right now. And there are a few different assessments that have to happen. And Dr. Moses will now take over and explain how she would approach such an issue.
Yeah, so I highly recommend, for a lot of my patients, I see a lot of women who are approaching marriage. And so we're analyze even to see if, just kind of see what your mom is doing, so that the first time you have intercourse is not the first time that those muscles have been stretched in that way. So if the person is comfortable with it, we do exams to just actually help you and give you some tools that you can do once you are married, so that you don't have that painful experience. We actually back it up a little bit before that point as well, and we ask a lot of questions about menstruation. And so, like, if your period is painful, even as a young person, so a 12 or 13-year-old girl having pain with periods, that is sometimes an indication that we can do a little bit of breath work, muscular work, to actually help normalize the tone in the pelvic floor, so that you don't spend 5, 10, 15 years having pain with your periods each month. And so I really love working with younger girls too, just kind of helping with that. We don't do any internal pelvic floor work with that. We just teach more breath mechanics and ways to kind of work with your own body and listen to your body. But one thing that I'm super passionate about is helping women have pain-free intercourse. I'm so glad you guys are talking about this, because a lot of women are told or inherently feel that they need to just endure. And so we really try to talk to our patients about you can have a whole different experience. So we do pelvic floor examinations that are, I don't even like to say they're like OB exams, because that makes people think of like stirrups and a speculum. So we don't use either of those things. We literally keep you draped most of the time, and we just assess the pelvic floor layer by layer. So there's 3 layers to the pelvic floor musculature that we look at and treat. So, and we also teach you how to treat yourself at home, and your partner can be involved as well to help stretch those muscles and strengthen those muscles. So it's very helpful. It's a game changer if you've had discomfort with intercourse, but also just for being able to experience pleasure and a full experience with your partner. And I can't remember what else we were talking about because the screen is not there anymore. Oh, I think you're muted.
Sorry, I was just saying that I took it down so we could say your face a little bit better. I'll put that PowerPoint up, but I did want to take a second and just note something that Dr. Moses said, that she does work with people as young as 13. Again, not necessarily with an internal examination,
No.
but this is something that Dr. Elias also talked about. And she said that that if you have, when Dr. Elias talked about if you have like a young athlete, that be aware of issues with young women who are athletes. Again, you don't have to be on a professional team, but somebody who is in a soccer team, even a casual soccer team, can have some issues. So
we actually have a high number of soccer players, ballet dancers, Irish dance, and softball catchers. A lot of the pelvic floor issues in athletes are actually in sports like gymnastics, anything that makes their feet turn outward. So when your feet are going out in your sport or activity repetitively, volleyball is another one, a lot of squats, that turns on parts of your pelvic floor that can kind of tighten too much. And so a lot of times people who have difficulty with pelvic floor dysfunction later in life, they are like, what is wrong with me? Like, I didn't have any trauma. I did all of the right things. I followed all the rules, and I'm still having pelvic floor dysfunction. And so that can be very disheartening for them. And so we go into like, what did you do as a kid? It doesn't have to be like I was, like you were saying, a collegiate athlete. Well, I mean, I danced from 4 to 15 or whatever, but that's a long time for your body to be in those repetitive positions. So, but yeah, we definitely screen for that and help normalize the range of motion in your pelvis and in your hips, and normalize that tone in your pelvic floor.
You know that Irish dance is one of the most popular Jewish activities.
I did not know that.
They're not. I'm just joking.
Oh,
volleyball
like,
is though. Volleyball is, especially volleyball, very, very popular. But
yes,
I actually once met a young woman who did do Irish dance.
Well, so I say that because I treated a whole team in Memphis, like the entire team. It was only 6 of them. There's 6 girls and 6 men, and all 6 women were actually having a lot of period pain, and they weren't able to have intercourse, and they were having fertility issues. So I added that to my list because there's so much pounding, and so so anyway, just in case anyone does Irish dance.
Do you want to maybe talk for 1 second about like using graduated stretchers? Is that something that you would do? Or that's something that you would refer to a GYN using?
We do recommend those. Usually we recommend an examination first, because we actually find that the muscles that are often the ones causing some of the issues are your deep hip rotators, which are like kind of on the sides. And so the dilators help with the muscles that we call the gatekeepers. So the technical term is Bulbocavernosis. There's so many muscles in the pelvic floor. I think when I was younger, I thought that there was just one, just the pelvic floor, but there are numerous muscles and we assess each one. So the gatekeepers are that very first line of musculature. So they're shaped kind of like this, and they line each side, they go around the clitoral hood, and they form this. And so a lot of the sharp pain that women feel with initial penetration is actually that muscle. And so those dilators can help with that. But we do.
So it
we
sounds
do
like
a
it's
lot.
important to not self-diagnose because there's so many different areas that we could be talking
Right.
about. Like I
And
mentioned before, there could be increased sensitivity because of nerve endings. There could be all
Right.
sorts of things. Okay, great. Okay, so I think we'll move on to the next question. So we're going to talk a little bit about the postpartum period right now. So after a woman gives birth, I will, again, in order to ascertain that the woman is ready to go to the mikveh, then a woman will be doing these internal examinations. And sometimes I'll get a phone call that says, I don't understand. I was really fine with Badikot before I got married, but now I'm really having trouble getting this Badika. It really hurts a lot, or it, I might be having a lot of bleeding longer than I think, or it just feels so sensitive. I'm nervous about doing a Badika. I'm nervous about having intercourse after having a baby. I'm nervous about going to the mikveh itself. Like, is the water clean? What's going on there? I had a lot of stitches. I had a lot of, I had like some tears in the perineum. I'm a little bit nervous about that. So I'll get phone calls saying, I'm really having trouble getting to the mikveh for all of these different reasons for after I had a baby. Can you please help me do these internal examinations, these badikot, so that I could get myself to the mikveh? So first of all, again, this is, there are a lot of parallels to the question about it before somebody gets married. The first thing, of course, I will say is, do not do anything that's going to cause you excessive pain. Please make sure that you have a green light from your doctor. Make sure that you're working with your GYN, your OB, to make sure that you're cleared for badikot and for intercourse. It's actually something super interesting that I've been Yoetzet Halacha, I think, for let's say 4 or 5 years at this point, but I've been teaching kalot I've been teaching women who have, and talking to women who have gotten married and then subsequent have babies for about 20 years. And I've also been a mom for 20 plus years. And I can't speak to people who have been dealing with this a little bit longer, but over the course of the past 20 years, and other Yoetzot say the same thing, who've been practicing for 20 years, that there has in general been an expectation that a woman could get to the mikveh a little bit earlier. Like, whereas, let's say 20 years ago, women really kind of expected to get to the mikveh in 6 weeks, 7 weeks, 8 weeks. Now I get calls from a woman after 2 or 3 weeks saying, like, I'm not getting good badikot, or it hurts too much. So one of the first things I might say is you might have to wait. It might be that it's too early. So it is important to realize that there's not a race. I know that we could be in a rush to get to the mikveh after having a baby, but sometimes time is important. So sometimes women talk to each other and like, I went to the mikveh after 4 weeks having a baby. That's very, very early. Some women can do it, but many women, it is totally normal that a woman can't get to the mikveh for 8 weeks, 10 weeks after having a baby. That being said, if somebody says, listen, it's been 10 weeks, like, or even it's been 7 weeks and I'm 7 weeks postpartum and I know I've stopped bleeding, but I really can't get the badika cloth and it hurts too much, or I'm doing a badika, I think I feel my cervix much lower than I did before. Or she might say, listen, I'm ready to go to the mikveh, but I'm really nervous about going to the mikveh. I'm nervous about the mikveh itself. I'm nervous about intercourse. So this would be a situation that, I would do my first aid, non-professional. I would say, well, try to do a badika more gently. Maybe you need a little bit of lubricant, which I've talked about before, how to do that before. Maybe you could lie down on your back to take some pressure off. Maybe make sure not to go as deep, breathe before. And I would say 70, 80% of the time, people will be like, oh yeah, I was just like, it's still sensitive. Realize that you've had trauma. If you have a vaginal delivery and even a cesarean section does mean that you've had some trauma. Go slow, go easy. And then many women will say, oh, that was much easier. That's fine. Or I might say, wait a week and try again. And women will say after a week, oh yeah, that was fine. That really was okay. And sometimes a woman will say, no, it's just not getting better. I'm still having pain. I'm still not able to do it. And at that point, is the point where we might say to Dr. Moses or and Dr. Elias, this is something we need to refer. And how would you treat a woman postpartum who is having these issues?
So we try to normalize a post screening for every woman who's had a baby for every baby. So this is standard in some countries. It's not standard in the U.S., and we're trying to change that because there's so much
Wait,
that.
Dr. Moses, I think we missed that first sentence. If you could say that sentence again.
Oh, I was just saying we are trying to normalize and standardize a postpartum screening for all women who have had a baby, and can be at any point. If you had a baby 14 years ago, still go get a postpartum screening. If you had a baby 7 weeks ago, still come in and get a postpartum screening, and have one after every baby, because there's so much that changes during pregnancy and during delivery and during the first few months of postpartum. So one of the things that we check first, even before we do any type of pelvic floor work, is we check your ribs. And this is one thing when I'm doing talks, I'll have a lot of women do, to just kind of check in with yourself. So if you check your rib angle, where you put your thumbs, if you can see me, if you put your thumbs under your rib angle, so here's your rib, and put it right here. So for a lot of women postpartum, the ribs are still a little bit flared outward, and they flare this way. And if that happens, it makes it
Dr.
very
Moses,
difficult.
I'm actually going to interrupt for 1 second. So for those of you who were in last week's session, like Dr. Eliza, was last week or 2 weeks ago? I think last week, we did a little bit of this. I'm going to say this is very important to review. So I think that Dr. Moses definitely go over this, but I think it's really important to connect information to previous information. We talked about this technique in a little bit of a different context. So those of you who sounds familiar, then you'll remember that we talked a little bit about this, and please continue.
Okay. So when your ribs are flared outward, it's very difficult for you to actually activate your pelvic floor, because your pelvic floor and your diaphragm are completely linked. So as you inhale and exhale and contract your pelvic floor with your breath and move your diaphragm up and down, they move together. And so if your diaphragm is having to work super hard because your ribs are out here rather than being down and in, it just adds more work. And it can cause what we call a diastasis recti, which some of you might have heard of, and it's where the linea alba is stretched thin. You can have a gap in between your rectus. There's a lot of scary things out there with talk about the diastasis, so I don't want anyone to be alarmed. And when you see things, don't be alarmed. It's just something that we can treat, and we definitely want to help you with that. So the first thing we do is just make sure everything is lined up. So we do rib work, shoulder work, and compression work up here. And then your actual pelvic bones shift during pregnancy and during delivery. So even if you have a C-section, your pelvis can still open. Each side may open a little bit differently and expand. So it expands outward at the top for the baby to come down and into the pelvis, which can help the cervix dilate and birth to continue. And then as the baby goes more into the pelvic bowl, the bottom kind of opens up a little bit so the baby can come out. So all of those things are super dynamic, and it's so helpful to have someone actually help your pelvis come back down and in to where it is. And we see this in women who have C-sections as well. So it's not just vaginal deliveries. It is because if that baby at any point was in your pelvic bowl, which she or he was when you were pregnant, you can still have some instability in your pelvic bones, or in the joint in the front where the pubic symphysis is, or the joints in the back, the SI joint. So a lot of women have clicking or some pain back there, especially with transition. So getting out of bed, rolling over, stairs, standing on one foot. And those are definitely things that we can help with to help you postpartum and during pregnancy. But basically we all deserve it. It just blows my mind that if we sprained our ankle, or if we had an ACL surgery, we would get weeks of physical therapy. It's just like the doctor's like, okay, just go to PT, But you go through 9 months of pregnancy and then a delivery in any form or way that it happens. And it's just silence. So we are trying to change that and give ourselves and give women and our daughters a chance to actually heal and normalize our tissue so that we don't develop a lot of these issues later on in life. Oh, I'm seeing some questions. Is there a benefit to physical therapy, pelvic floor PT after C-section when the same muscles aren't strained? Absolutely. So one of the things that I think is not understood in the general public is that a C-section is still a beautiful delivery. It is, your baby still came forward out of your body. It is incredible. It's a miracle. We're so grateful. And you still need care. Like if you had had an incision anywhere else in your body, especially if it had cut through 7 layers of tissue, like you should think that you should have some help on that scar, normalizing that tissue, helping those muscles work better. But for whatever reason, women are not told this. So I'm telling you, it's so impactful to actually have someone help your scar move. So we do scar work to help each layer of tissue move. We do internal work as well on the pelvic floor because the pelvic floor was affected with your C-section as well, and it can be so impactful. I have a lot of patients say that they have incontinence or have issues after having a C-section, and they don't feel like they deserve or that they should have that because they didn't have a vaginal delivery, but you still went through a pregnancy and you still went through a delivery.
So true. Thank you so much. And if you remember last week, Dr. Elias talked about like specific things to do for a C-section tissue, the C-section scar. So remember that like all of those things, as Dr. Moses just mentioned, that it's not just the functionality in the pelvic floor, it's also the scar that really could use some help. Okay, thanks. Okay. The next question is going to be also a little bit about stress incontinence. So just a little bit of background and information in terms of Jewish law. One of the things that I teach all the time, so I'm just going to interject a little bit because I still get questions like this. It's very, very preventable. When we talk about blood or uterine bleeding that causes a woman to become impure, to become tme'ah, the way that it's described in the early halachic literature is that for a real period, real menstrual bleeding, real uterine bleeding that's going to be hormonal, like that's really the way that it's described in halachic literature, is accompanied by a feeling, some sort of hargasha, some sort of feeling that indicates that this bleeding is uterine, that this bleeding is menstrual and is not, some other like a scratch on the cervix or something else. Okay, there's always supposed to be some sort of feeling, and that's really to be on a Diastasis level, like the most strict level of tumah, of impurity, then the bleeding is accompanied by a feeling. It happens to be that we've really noticed that the way that the Gemara, the way that the Talmud describes this feeling, almost nobody has. So rabbinic literature has developed other ways of dealing with bleeding that's not accompanied by a hargasha, bleeding that's not accompanied by this feeling of shaking or the uterus opening or those kind of things. So of course, many women do have cramps or symptoms like diarrhea before getting their period or something like that. But it generally doesn't fall into the category of a hargasha. That being said, the Talmud says that sometimes there's certain activities that we're nervous that it could be that that a woman did have this hargasha, even if she normally doesn't. She had a feeling, and maybe some other activity covered up or distracted her from the feeling of the hargasha. So we assume she might have had hargasha on a Diastasis level. On a Torah level, she might have Torah level bleeding instead of the rabbinic level bleeding. Again, like I've had a shiurim about this, so if this is confusing for you, you could kind of ignore it. But I just want to access some knowledge that some of you might have or hopefully do have. For those reasons, this is the practical thing that we always advise women that after you urinate, please, please, please wait 15 seconds before you check what's going on in the toilet. It is important to know if there's blood coming out of some gynecological or uterine or anal kind of bleeding, so that you might pick up on in the toilet or on a tissue on your underwear. It is important to know if there's bleeding. However, please make sure that you wait 15 seconds after urinating before you wipe or before you look in the toilet. Because if somebody calls me and says, I just went to the bathroom and then I stood up right away and I looked in the toilet and I saw a clump of blood, am I nida, am I impure, then I might, we might have to go through it, but a woman might end up being impure. However, if a woman calls me and says, I just went to the bathroom, I waited 15 seconds, and then I looked in the toilet and I saw a clump of blood, almost always she's not a nida. She doesn't have to go to the mikveh. So I'm going to make a plug. Please, please, please make sure that you count 15 seconds or at least 10 seconds between urinating, standing up, between urinating and wiping, okay, for those halachic reasons, because we're much, much, much more strict with blood that you see in the toilet bowl, on the toilet seat, on a tissue, if the blood, if you wiped immediately after urinating. Okay, so sometimes a woman will say to me, I am I'm having stress incontinence. I'm leaking urine in reaction to activity, or just all the time, or because I sneezed, or because of some other activity. And then I saw blood. So does, if I'm leaking urine because of stress incontinence, then does that count as urinating? Like, so if I know that I was leaking urine and then I saw on the tissue or underwear, then does that count? Is that a problematic blood? Okay, so that's a question that I get. So almost always that's not considered a problem, because when the Gemara talks about urinating in the context, it's very, very, if you're interested in these things, you could actually look at the original conversation in the Gemara. It's actually really interesting. There's a whole, it's interesting sociologically about the way that toilets used to work. So you could look it up, and there's a whole conversation about different ways of your sitting, standing, using a bedpan, using a safsal, which is like, I guess, like a chamber pot, not using one. There's a whole different conversation about different ways that people used to, before they had toilets, all different ways that people used to go to the bathroom. But part of the conversation is that it's really a stream, that really if somebody sees blood in a stream of urine, or with a stream of urine, or immediately following a stream of urine, then that could be an issue of halacha, right? That could be considered blood that would make a woman impure. Side note, blood in urine also is really an issue, right? So generally, if a woman has blood in urine, a lot of blood in urine, or habitual blood in urine, then it could be, God forbid, a mild or more serious bladder issue, urinary issue. So it's important to get that taken care of. And that's a different medical professional that you really should be seeing. But in general, we're going to focus right now on leaking urine. So again, seeing blood with leaking urine is not a NIDA issue. It might be a urological issue. But I want to focus, if a woman asked me this question, then I would say, oh, you're leaking urine, you're having stress incontinence. That is not something that you should be dealing with your whole life. Dr. Moses, I'm actually going to steal her thunder. She said that incontinence does not have to be the new normal. It's not something that you have to accept. So again, if a woman comes to me and says, I'm having stress incontinence, I'm leaking urine, I might say, okay, not a halachic issue, but that's a quality of life issue. Perhaps you should see somebody about that. And I will just and I will pass this over to Dr. Moses to talk about how she might deal with that.
Yeah, so the number one reason for women and men to enter a nursing home is incontinence, and the number two is bowel incontinence. So urinary and bowel incontinence are extremely common, especially in our country, but they are not normal. So one thing that I tell my patients is that once you've been potty trained, you should remain that way throughout your lifespan. So we work to help that be possible. Our patients in general, they a lot of times have been having issues with incontinence for a long time, or they didn't even realize what they were experiencing was incontinence. So there's a couple kinds of incontinence. So there is stress incontinence, which is usually laughing or coughing or jumping. Something is like causing you to use your muscles and you leak a little bit. And that's not always because your muscles are weak. We more often find that your muscles are usually more tight or on all the time. And so when you use a sneeze, like something that's like big motion, or a jump rope, or even just like one, like you stepped off the stair weird and then you have a little leakage, that's usually because your muscles are already on, they're in a resting state that is too tight. And so they don't have enough like leftover strength to be able to support the bladder. And so you have a little leakage. But there's multiple things with bowel and bladder function that we can address with that as well. So another type of incontinence is urge incontinence. And that's the type where when you feel like you have to go, it's really hard to get to the bathroom in time. And so that can lead to incontinence, especially the longer you have that issue. And so I'll give you a couple of tips just to help prevent that from happening, and to kind of check with yourself to see if you're already starting these patterns or starting them for your children. So one of the main things that can contribute to that type of incontinence is hovering over restroom toilets. So especially public restroom toilets, a lot of women won't sit, so they'll hover, and that disrupts the natural body system where your muscles have to turn off in a sitting position or a low squat. And so your bladder learns to ignore the fact that your pelvic muscles are on, and so it will start backing it up. So you'll starting to leak when you're like getting your pants down, and then it'll get even sooner. It's like as soon as you close the door in the bathroom at Target or whatever, you're like, I'm going. And so it gets worse and worse and worse. So we try to not do that, and tell all of your friends, do not hover. Another thing is to not have a trigger. So if every time you wash your hands or you hear running water, you're like, oh, I have to go to the bathroom. And then if you continue to do that, you actually are training yourself to let an external signal tell you to go to the bathroom. So it's the Pavlov's dog situation. So instead of like your body, your bladder communicating to you, I have to go to the bathroom, you're letting something external say, go to the bathroom. And so that gets worse and worse. I had a woman who she would always go in the shower, and she was at the Children's Museum, and a bucket of water dumped on her head, and she couldn't control her bladder because her bladder was so used to that happening. So with the on the head, it was a signal to go to the bathroom. So anything like that, that's a signal. Or a lot of women have their trigger is getting home, because if you immediately, every time you get home and walk in the door, you go to the bathroom, then your bladder will start to learn, oh, as soon as I get in my garage or in my driveway, I need to go to the bathroom. But there's a lot of urinary issues that we treat, and it's not always Kegels. A lot of times it's the opposite. It's normalizing the tissue and the tone in the tissue, and normalizing what your resting state around your bladder is, so that when it needs to turn on, it can.
Okay, great. Thank you so much. I know that it's something I will actually say that my mom is actually on the call, so I will say that we used to make fun of her that every time Mommy, I'm outing you. I hope you don't mind, but I'm outing myself also. Every time that that we used to like walk and she had a sneeze, she would have to like stop. She'd be like, hang on, like you have to stop
Yes.
walking. And then we would laugh at her. And my mom used to say, just wait. And now, of course, four kids later, I always say to my kids, I'm not going to wish this upon you, but so I will also tell them, go to somebody like Dr. Moses or Dr. Elias. And
so I forgot to mention one thing too. So one thing that we're finding that is actually affecting our pelvic floors too are wearing like really tight pants or binders around the lower abdomen, or even the rectus itself, like the abdomen. So pulling in all the time with an external force, it limits the amount of just daily little stabilizer muscles that we have to use every time we lean over to get something, or breathing, like just the internal muscular system that has to be working daily with these tiny, tiny little movements that you're doing. Those support your bladder. And so what we're finding is that when we're wearing these really restricting yoga pants or Spanx or girdles, or just tight jeans, even to just kind of suck us in and hold us in, or even having that posture within ourselves, that we're actually weakening our pelvic floor, and we're having more issues with prolapse and bladder dysfunction. So we're having issues where more women are having incontinence, or just not even being able to tell if they need to go to the bathroom because they have this external component taking the place of their muscles. So that's something that we help with as well. We help retrain those like really small postural muscles that can support your bladder, your pelvic organs, and help with low back pain. Because if you aren't using the front musculature, your back is going to do all of the work. And then a lot of women have glute pain and back pain. So we work with making that work in synergy when you're doing functional movements. And if you guys can go, I don't know if you'll have access to that survey at the beginning. There are a lot of urinary issues and bladder issues and sexual issues. I don't know how much time we're going to have, but I would talk to you guys all night about this. But there are so many little things that a lot of women don't even realize are issues. And a lot of times we kind of put ourselves in this box of like, I don't have pelvic floor issues because I'm not leaking. So it's not just, that's not the only indicator of you might need a little assistance with your pelvic floor. Like any of these things, even just sitting on the toilet and having to wait 10 to 15 seconds for you to start the flow of urine can be a sign that your pelvic floor is too tight. Or like you feel like you can't empty fully. You have to like sit there for a long time to let the rest of it come out. Or if you stand up and a little bit dribbles out, all of those things are things that we can help with and that should be helped with. And another common issue that we have a lot of patients that have catheters, and so that affects the urethra. And so we do work around the urethra to kind of restore that tissue and get rid of any protective tone from having a catheter. Like I literally have my patients say to themselves, like, I don't have a catheter in, and they're not going to put another one in. And you would not believe how many little urethras feel so much better afterwards because they aren't anticipating that nurse come in and give them a catheter. So it can be very helpful to just kind of review this screen and just see everything I put on here can be helped with pelvic PT. And it should be. Like any things are not necessarily just that they are a symptom in themselves, but they are often a sign of an area of dysfunction that we can help with.
Okay, thank you so much. And I also want to just point out two things that I'm noticing is that number one, how many of the issues that you're talking about are things that came up in like all these different areas. Like just as an example, Dr. Moses, you talked about having an external binder or something, an external pressure. And last week, Dr. Elias talked about like the value of having external things to help with posture. That and something that you both talked about is that balance between using a device to help, but also sometimes then it's used as a crutch, and your muscles then don't do the work themselves, and that could have other long-lasting things. And there are so many, or the general things. Something that I hear time and time again is that we always think of Kegels, and also Dr. Elias talked about last week and the week before. But it's so much. There's so much. It's so important to realize that relaxing is as equally as important.
I don't even use the word Kegels in my practice. Because so many women too, when they're doing Kegels, and we actually test this, we say do a Kegel, and almost always the women are just doing a sphincter squeeze at the very opening, which actually is more, it's not as beneficial because that is the same muscle that can hurt with a tampon or with intercourse. And then when I actually teach them and show you where all your pelvic floors are in your pelvis, and teach you how to engage that with your transverse abdominis and your lower abdominal musculature, and then I say do a pelvic floor contraction, it is completely different. And it's incredible because then they can actually feel the tightening and the lifting that has to happen in the pelvic floor for that strengthening to happen.
Right. So for those of you who hear, I think it was last week that Dr. Elias showed that image of the elevator going up the skyscraper. That's what Dr. Moses is thinking about. That lifting instead of just the squeezing. It's all about lifting and pulling, and the entire Pringle can. So I'm just going to reference that.
Right. I'm going to say one more thing about that too.
Please.
So a lot of women who have pelvic organ prolapse, and which is actually very common, and it's not just in older women, it is so common after childbirth. So, but a lot of women, when they hear they have pelvic organ prolapse, they think, I need to tighten and lift all the time. And so you find yourself kind of doing that all the time, which is one, exhausting, and two, it defeats the purpose, because then your muscles fatigue because they cannot hold pressure that whole time. Whenever you do that, I have to like switch back over here because I'm looking. So anyway, and so it actually is more exhausting on the muscles, and you can have increased pelvic organ prolapse symptoms. So we highly recommend seeing us for help with that, so we can teach you how to do that dynamic. And we can also help with things like pessaries and things that help support your organs.
Amazing. Thank you so, so much. We're going to go on to our last question because we're reaching the end. So the last question, and this is something that we framed this question in terms of menopause, because we're going to talk about, two different issues here, is uterine or other organ prolapse. That's not only uterine, and menopause. So the question that this is actually not a question that I got, but a question that a friend of mine got, is a woman who's menopausal and had not had her period in quite some time. She called and she said, I'm seeing vaginal bleeding, and I don't know, does that make me impure? Is this uterine bleeding? Is it hormonal? Like, what is going on? I'm seeing bleeding. And her question was, am I now nida? Am I now impure? Because even though I'm post-menopause and I haven't gone to the mikvah in 5 years, I'm now seeing blood. What do I do about this? So as part of the conversation, my friends started talking to her, and it became clear that the woman had a uterine prolapse, and she was seeing blood, probably as a result of cervical irritation. That Dr. Moses will talk about the definition of prolapse in a minute. And she said that and further, it came out in the conversation that this woman had this prolapse for years and years and years and years since since her postpartum period, but through menopause, her prolapse actually had gotten worse, which meant that the irritation to the cervix, which was really, really low in the vaginal canal, that the cervix was starting to get more irritated, and she was seeing blood. So the halacha question in that is that it actually really depends. Bleeding from a prolapse can make a woman a nida, depending on the situation. There actually is an entire conversation in the Gemara about blood, about having significant tissue in the vaginal canal. It's not so clear what the Gemara is talking about, but many people think it's actually talking about a uterine prolapse. So if the uterus is very, very low and is it partially or even more fully into the vaginal canal, then if a woman gets her period, then yeah, she's going to have uterine bleeding through the prolapse, like through the prolapse uterus. So if the bleeding from a prolapse uterus is uterine, is hormonal, then any other uterine, like every other uterine a hormonal bleeding, then she's going to become, if a woman has a prolapse uterus and she's having her period, then yeah, she becomes nida just like she would in any other case. What is different is that she has to be very careful in her transitioning from becoming a nida to going to the mikvah, as she does her internal b'dikot, then she has to be very careful that she doesn't irritate the cervix, and she should be careful about how she does a b'dika. She should not go as deep. She should only really focus on the walls of the vagina that are not affected by the prolapse, or lower from the prolapse, because it's really important not to, for many reasons, both medical and halachic, it's important not to irritate the cervix. So to sum up, if the prolapse is causing a woman to have, if a woman is having her period, or other fibroid uterine bleeding, we'll talk about fibroids, by the way, some other point. I'm not bringing fibroids in, but if a woman is having uterine bleeding, hormonal bleeding from her uterus, then that would make her nida, whether or not the uterus is higher or is prolapsed. However, if a woman is having bleeding in a way that she would not expect, and you can attribute it logically to the cervix, whether she's premenopausal or not, then if you could logically attribute, say, if she says, this is not my period, I shouldn't be bleeding, I think I scratched my cervix, and I'm seeing some blood, then we would say that the woman does not become nida, because it's dam maka, it's the wound of scratching the cervix or irritating the cervix, and that blood is not uterine. Okay, so to review, that if a woman has a prolapsed uterus, then we would treat any blood there, we would like we do with a non-prolapse uterus, we would try to determine the source of the blood and figure out whether she's Anita or not. Of course, each conversation, each case has to be discussed by itself. I'm bringing this up because it's a question that does come up. But now that we're talking about a prolapse uterus, then I would like Dr. Moses is now going to address two issues. One is organ prolapse. Again, there are different organs that could prolapse. And the second thing she's going to discuss is pain during menopause, which, as she says with everything else, menopause is a fact of life. Menopause does bring transition. Menopause does not have to bring pain that's untreated and that just stays. So if Dr. Moses, we're approaching the end. So we have, let's say, about like 5 or 6 minutes to talk about these. You can go over 1 or 2 if it's important. And then we'll have some questions at the end so that people, if people have further questions, then we'll stay on and answer questions, and otherwise you can go. So addressing these last 2 issues, Dr. Moses.
Okay. So yeah, so you can have a pelvic organ prolapse from either your uterus, cervix, bladder, rectum, or all of the above. So, but I don't want that to scare you all. That's actually very common, and it's something that you don't have to have symptoms from. So a lot of you do have symptoms, and that's what we always want to work with you with that. And sometimes surgery is advised and so helpful. We try to catch this super early. So the reasons we like to do the postpartum checkups. And if at any point you do get diagnosed with a prolapse, we highly recommend pelvic PT, because a lot of times it can help with normalizing the downward pressure. We can help restore the muscle integrity around the organs and the fascial linings around them as well. So there's a lot we can do. We may not be able to completely correct it all the way, but we can still help you potentially not have the patterns that were contributing to it in the first place. I have a cystocele and a rectocele, and those are the bladder and the rectum. And I have no symptoms. I don't have any incontinence. I don't have any bladder issues. There's a lot of things we can, rectal issues. There's a lot of things we can do to help with that, and we highly recommend it. So one of the things another little thing I'll throw out there for you all that can help is having good potty posture. So I don't know if you all have seen the little stools that go around the toilet. Those can be very helpful for having bowel movements, because it can actually help line up your rectum a little bit better and not have that downward pressure. But one thing that I really want to share with you all is proper breathing patterns with having bowel movement. So not just the way that we teach it is to actually, when you're having any type of bowel movement or birthing a baby, this is the way that you are that we teach you how to breathe. So when you are in that position, we teach you to inhale and lengthen your pelvic floor. So you're actually you're not pushing, but you're just kind of opening your pelvic floor. And then when you exhale, the pelvic floor naturally lifts a little bit. So we don't want to push with our exhale, and we don't want to bear down or push when there's no air moving. So holding your breath and pushing. So if you will try that next time you have a bowel movement, actually, when you inhale, just kind of not push, but you do kind of you just open. You think about it just kind of relaxing like that. It's a game changer. And then with all of our pregnant patients, we teach that technique so that when they're in the delivery room, that can actually help open the tissues rather than every contraction being a closed glottis or the closed neck and throat and the pulling in from the pain. So it can make a big difference. But menopause in general, we highly recommend having pelvic PT during pre-menopause, during the whole thing, because off and on, even if there's issues that come up, we have so many women who have either been told or just believe that that intimacy is over once menopause starts, and and a lot of that is because it's not always comfortable, because there's a decrease in estrogen, the tissues get thinner, there's not as much lubrication. There can be some changes that happen on a physiological level that contribute to it being a little bit more painful. But when your body interprets pain, it will tighten, which makes that whole pattern happen. And that happens in menopause or anytime intercourse is painful. it causes your body to say, I don't ever want to do that again because it's going to hurt. And so that makes your muscles actually make it more uncomfortable. So we want to get out of that loop. But in menopause, we highly recommend just getting your muscles stronger. I mean, our ladies that are in menopause and after menopause have vibrant, intimate lives, and they aren't in pain, and they are just, their tissues are healthier. It's like working out a little bit. So your tissues get blood flow, they get more lubricated. You don't just have to have estrogen to have that. Like, you can actually like kind of strengthen that part of your body. So we love working with our menopausal women. Oh, there's a question. Do you need to do a DNA? I'm guessing, I don't really know what that is.
Sorry, that one is for me. Oh, is that for you? Okay, I actually wanted to maybe open up now to questions. I'm going to pause the recording.